Hi, Sunny.
Hello. Good afternoon. How are you?
Hi. Good. How are you doing?
I'm good. I'm good. Just hanging back here in the background so long.
Sure, no problem. Hey, Gummy. Hi, Gazi. Doctor.
Hey, you guys, how are you?
There we go. Well, thanks. How are you?
Excellent.
Are you comfortable with how to share your slides on Zoom, or would
Yeah.
you like to
No, I'm
practice?
okay. We can actually share the slides
Okay.
now. Zano, if you actually allow me to, so the slides you send me, I see that you've hidden some of the amplified data. Is that intentional or this is something I did in the past?
No, no, we did not hide it. It may have been something you've done previously.
Okay, because I
Yeah.
was like, wow, this is the most important topic. Okay, let's do this. Perfect. All right. Uh, Perfect. All right. Let's do this. There you go. Does that look fine?
It's loading. Yes, that looks. And do you want to see if it is nice? Dr. Alatipi, do you want to see if the slides advance? There we go. Perfect.
Afternoon, everyone. Afternoon, Dr. Ghazi.
Hey,
Good,
Gummy.
good afternoon, my friend. How are you?
I'm well. I'm well. Thank you so much, and thank you for your patience.
Oh,
Um,
absolutely.
all of my
Is it
Wi-Fi routers decided to stop functioning, so it's been a bit of a frantic.
no, it's okay. It happens. Is it very hot where you are right now? Because in Riyadh, it's
Um,
boiling hot.
I can imagine. I get the impression Riyadh is hot most of the time, although I've only visited once in winter.
And you're complaining, eh?
We're in the middle of a change of season at the moment.
I see.
Um, so it's Cape Town is very unpredictable. It was warm this morning, cold by midday, and now it's getting warm again.
I see. Yeah, but
Mhm.
at night, it's wonderful. I've
This,
been there once for like 24 hours, but I remember it was like a lovely weather.
that's amazing. It would be great for you to visit again, of course.
Much
Have a talk
appreciated.
in person. That would be really great. Um,
I think we'll rely on our colleagues at AstraZeneca to bring us together.
yes, are you listening? Listening to hear us?
Oh,
So,
goodness.
Gummy,
Getting us into trouble.
I've
Yes.
given you slide control.
Thank you.
Okay, great. Um,
Somehow go back to the beginning.
okay, great. So I'll be able to
You'll be
slide
able
through
to click through. Yeah.
I'll be able to slide through our introductory slides. And then will you hand over control to Dr. Ghazi for his slides or?
Okay, so I'll stop sharing. You can share your slides.
Yes, so he will share
initially.
his slide.
Perfect.
Perfect.
And everything is on the screen, so you can just read through the introductory stuff on it.
Okay, no problem. Thank you. It looks like we almost have a quorum. 48 participants have joined so far. And it's almost 4 o'clock. That's good timing. I think everyone's as excited to hear your talk as I am, so that's good. I'm just pulling up one or two things here.
Thank you, Dr. Gamu, for agreeing to chair. Much appreciated.
It's a pleasure. It's a pleasure. It's an honor to chair one of these sessions and this particular session. So, yeah. Looking forward to it. So I think it's I think we're almost ready to get going. Okay, good afternoon, everybody, and welcome to today's deep dive session. I'm sure you're all looking forward to it as much as I am, the evolution of CLL. We'll start with a bit of housekeeping. Today's deep dive is brought to you by Blood SA and AstraZeneca. Thank you very much to our partners at AstraZeneca for bringing us what promises to be an exciting session. Many thanks to the deep dive management team, Professor Verberg leading the team, along with Dr. Gerdine Kritzinger and Dr. Nicholas Smith. Just in terms of a bit of housekeeping, as you know, all of the sessions are recorded and will be found on the Blood SA website under resources. Please feel free to add questions or comments to the chat box so that we can respond to those at the end of the presentation and just stimulate some conversation around the topic. In terms of CPD, there will be points submitted to the HPCSA for each registered South African attendee. And just make sure you're attending with your own registered Zoom link and not in a group for your CPD points to reflect. And you need to attend for at least an hour. Make sure that your HPCSA number is entered correctly when you sign up for deep dive. And of course, if you've got any queries, please email admin@bloodsa.org.za. For the mailing list, there is a QR code, or you can go to the website under resources or subscribe to Deep Dive. And of course, feedback is very important. Blood SA and the speakers value your honest feedback, so please complete the anonymous survey at the end of the Zoom meeting. And then very important, I hope you've all registered for and are getting ready for our 17th annual Heme Onc conference that will be at Century City here in Cape Town from the 19th to the 21st, Bridging the Gap. Haematology in Action, Bridging the Gap is the theme for this year, and we're all really excited about it. And this is obviously in association with SAHAS. And then, of course, just to highlight, we will be having HHT Horizons as well, collaboration for innovative care in South Africa on the 19th of September, the Century City Conference Center in Cape Town. So please keep that on your calendars as well. Okay, so our agenda for today, we're going to be focusing on the evolution of CLL by Dr. Ghazi Alotaibi. And then this will be followed by a Q&A as well as closing. And then Just to introduce our speaker for today, Dr. Ghazi Alotaibi is an American and Canadian board-certified internist and hematologist. He's currently serving as an assistant professor of medicine at King Saud University and practicing at the King Saud University Medical City. He leads the King Saud University Hematology Fellowship Program and chairs the Cancer Therapeutics Subcommittee within the Pharmacy and Therapeutics Committee. He completed advanced fellowship training in myeloma, amyloidosis, and dysproteinemia at Mayo Clinic, Rochester, and holds a PhD in experimental medicine from the University of Alberta, where his research focused on the epidemiology of venous thromboembolism. His expertise encompasses a wide range of hematological disorders, clinical trials, and translational research, including multiple peer-reviewed publications and collaborative projects on thrombosis, anticoagulation, and hematologic malignancies. As a dedicated educator and clinical investigator, Dr. Alotaibi is a member of the American Society of Hematology and the International Society of Amyloidosis. He is committed to advancing patient care and mentoring the next generation of physicians and researchers in hematology. And you'll be happy to hear that we have many trainees on this forum. So we're really looking forward to having your talk. Next week, just to give an announcement, we will be having a session on palliative care by Dr. Renee Krause. And I think at this point, I can hand over to you, Dr. Alotaibi.
All right, thank you very much, everybody, and thank you, Dr. Tad, for the great introduction. To be honest, I did not write this introduction, and I do not agree with some of the statements. So my name is Ghazi, and I'm a hematologist by practice. I used to do a lot of things, but nowadays I only do myeloma and CLL. So that's a disclaimer. So, it's always a pleasure to talk to colleagues from everywhere, and our South African colleagues, have been quite a pioneer in a lot of hematological things, and it gave me a pleasure, when the team invited me to talk. So, CLL, here we go. So this is a sponsored activity by AstraZeneca, and as you know, AstraZeneca makes Calquence or icaloprutinib. But I've got research funding from so many companies, but mostly for speakers' fees and advisory boards. And some of the stuff mentioned in here might not be approved in your approval body, but most of the indications here are approved in Saudi and by Saudi FDA and by American FDA. So when you actually talk about CLL, if we have given this talk 5 years ago, I'm sure the content will be different. And if I give this talk, in 5 years from now, the content will be completely different. But in general, when we looked at CLL throughout the last 20 years, we can actually all agree that there's a lot of heterogeneity when it comes to CLL. There are actually patients who come with a very indolent sort of disease, and there are some other patients who actually present as a leukemic variant. Some people who actually present as a lymphoma variant of CLL. But we are all I think, in agreement that the RAI and the PNA staging are still what we use nowadays. Whether we document this or not. And then some of the biomarkers that came through the literature, they've disappeared. But nowadays, FISH is very important to at least recognize those with complex cytogenetics. We might not be acting too much on the FISH, but it's something to keep in mind. And IGHV mutation is very important, especially when people present to the clinic, because it helps you stratify those people and choose what is appropriate for their therapy if needs be. We definitely have to agree that TP53 mutation is very important, and this is something we do at the time of diagnosis, and we also do it at any point in relapse. I mean, the TP53 mutation, we don't do it at diagnosis. We do it at the need for therapy. So sometimes, when people present and they're for watch and wait, we do not do it, but we definitely do 17p plus TP53 mutation. So 20% of the 70p deletion patients, they are not TP53 mutated, and vice versa. So these are the most important biomarkers, and we put all of this together to inform your management. So in the past, we've all, learned from the initial, 1990s literature that certain chromosomal abnormality can actually result in differences in PFS and overall survival. I do not think this applies to today's combinations, but it's, as a disclaimer, we always, talk about, DIL13Q being, a good cytogenetic abnormality, and trisomy 12 as, something in between, and, DIL17P is the worst. I have to say this is in the era of chemoimmunotherapy and might not be applicable to today's therapy. But we all agree that IGHV mutation, it depends on which therapy you use, but, a mutated IGHV patients, they actually do quite better than unmutated. And this, has been shown from the initial publications on the FCR literature, with the MD Anderson group, literally in the 80s and in the 90s. The patients who are now coming to the clinic, they will probably get a CLL IPI, and in that case, we're just looking at certain basic clinical characteristics plus, TP53 and IGHV mutation, and you can actually stratify those people to, whether they have a high risk or low risk disease, and their overall survival, varies significantly. Again, and all of these, IPI scores were actually also done in a time where chemoimmunotherapy is the backbone of therapy. But I think the CLL IPI is easy enough nowadays that I think it can stratify those patients, even if your therapy is a non-chemoimmunotherapy based, and we'll talk about these details. So, is it important to check for TP53? I think it's probably one of the only biomarkers that still actually holds when it comes to prognosticating patients. We know that people with MPL, they rarely have a TP53 mutation. People who, when they present at the time of diagnosis, they do not require, or they do not harbor TP53 mutation in at least 95, 97% of those patients. But with therapy evolution, the clone of TP53 usually increases, and usually at the time of relapse disease, you're looking at maybe 50% of those people. So it's very important to look for TP53 and 17P with every therapy that you start. And the responses to therapy depends on TP53. So it's very important in also choosing the appropriate therapy for those patients. So just, picking on a simple case from the clinic, if you see somebody who's 42, and this is actually one of the patients in the clinic who came with a diagnosis of CLL, and at the time it was a RICE stage 4 with hepatosplenomegaly and thrombocytopenia. If you actually calculate the CLL IPI, the score gave it intermediate, so there is no TP53 aberration. IGHV is mutated, which is a good thing. Beta-2 microglobulin is mildly elevated, and the patient's age is young. So CLL IPI2, not really bad when it comes to prognostication. So the question that always comes in mind, okay, so do we need to treat this patient or not? I think that's probably the commonest, sequence of event. And I think with the hepatosplenomegaly and thrombocytopenia, everybody will agree that, this patient will need therapy. So do you do BTKI continuous? Do you do venetoclax obinutuzumab? Do you do a combination of BTKI plus, obinutuzumab? Do you do triplets? Now, we're becoming more like a myeloma now. We're doing, doublets and triplets. So BTKI, BCL2, and obinutuzumab, or would you actually go for an FCR, looking at this patient who's got an IGHV mutated and he's young and fit and probably can tolerate an FCR? So these are probably the options that every CLL physician will consider in mind, and I think by the end of this talk we'll be able to convince you that probably everything is possible except FCR. So currently available treatment, the armamentum is actually expanding. So initially we've got bendamustine rituximab as a backbone. Prior to that, chlorambucil was also an option, and moving on to the 90s, FCR came as a very important therapy in CLL, and it actually changed the landscape of CLL. But most recently, in the last 20 years or 15 years, rituximab and obinutuzumab have added so much to CLL, survival. And then probably from 2013 onward, so about 12, 13 years, we started to hear about, ibrutinib, acalabrutinib, and more recently zanubrutinib. Now we've also I've got a new class of medication that are actually non-covalent binders to BTKI, so pirtobrutinib and nirtobrutinib, and some of these are actually approved even in the part of the world where we live in. So PI3 kinase, I'm not really a big fan, but idelalisib and duvelisib are actually options for refractory diseases. And now, recently, the combination of venetoclax and sonrotoclax have been evolving as a combination therapy. So quite a bit of change. Prior to 2015, we used to only talk about either a chlorambucil with or without obinutuzumab, pinnamasel rituximab, or FCR. That's pretty much it. Now, so many options, and the patients can actually live pretty much a functionally normal life. So aligning, our current clinical practice with international guidelines, the NCCN guideline would, recommend for such a patient we described either a combination of venetoclax or obinutuzumab, and this is based on the Gaia and the CLL14 clinical study. And then, some of those people who are actually young and fit and they do not have high-risk genetics will benefit from a fixed duration therapy, venetoclax, obinutuzumab, plus acalabrutinib. So it's quite an interesting combination, and we'll walk through the data. And it's actually not wrong to use the Elevate protocol. So the Elevate TN will use acalabrutinib obinutuzumab, and I'll show you that obinutuzumab adds so much to this group of patients in comparison to rituximab. Is it wrong to give somebody a BTKI continuous therapy? I think it's pretty much a common practice in some centers where they can actually use a BTKI, and I would probably favor a second generation, either an acalabrutinib or a zanubrutinib. In this young and fit patients, venetoclax ibrutinib is also reasonable. Ibrutinib is becoming generic; it's cheaper, so the combination with venetoclax is probably reasonable. And then ibrutinib from the Alliance and the Resonate, is actually an okay option for those people. If you actually look at the most recent NCCN, and for the last, I would say 10 years, they have not eliminated FCR as an option for this kind of patients who's, as in our case, 42, IGHV and IGHV mutated and non-TP53 harbor. So those patients can actually tolerate FCR. But I will try to make a case to tell you that, it is probably not the right choice here. In the TP53 mutated patients, the bottom line here is, they will benefit from a continuous therapy. So keep in mind the NCCN preferred regimen is based on alphabetical orders, but I think my preference will go toward a continuous therapy, either with first or second generation BTKIs. But if in those young patients who would want a fixed duration or finite duration therapy, VO is an option, and then the venetoclax acalabrutinib obinutuzumab is an option. And again, from the CLL14, those group of patients are actually excluded, but we can extrapolate from the 10% they were enrolled in the study that, it's a reasonable option. So looking at the ISMO guideline, it is not too different from the NCCN guideline. And again, the ISMO guideline is mainly designed to push for reimbursement in Europe. But I think for the patients who's fit and young, VO is probably a great option. Ibrutinib venetoclax is a better option when it comes to a longer PFS. But what's even a much safer option is probably acalabrutinib obinutuzumab, or monotherapy with ibrutinib, acalabrutinib, or zanubrutinib. They still kept chemotherapy FCR, but again, this is for reimbursement purposes. In the unfit patients who are not high risk when it comes to genetics, VO is a reasonable option. Acalabrutinib obinutuzumab is a wonderful option, and this is again based on the Elevate TN. And the acalabrutinib obinutuzumab have also been compared in the Amplify, and we'll cover this in the last slides. So in the high risk populations, if they're fit and you don't want to commit them to a continuous therapy, then ibrutinib venetoclax is reasonable. Ibrutinib as a continuous therapy is a good option. Continuous therapy with acalabrutinib obinutuzumab in the Elevate TN is a more safer option. Zanubrutinib from the Sequoia is a wonderful option. So those patients have, they can actually benefit from certain combinations based on, their preference. But in those who are TP53 mutated, and the ISMO guideline is actually quite clear about this compared to the NCCN. If they're TP53 mutated, then the preference will always go to a continuous therapy with a monotherapy BTKIs, preferably a second generation, so acalabrutinib or zanubrutinib. Ibrutinib is not probably recommended for those people because of side effects. Venetoclax is in my mind not a great option, but it's a combination that they have mentioned. So how do you choose between therapies? Again, so many things, but mostly comorbidities, what coverage the patients will have, what access to medication do they usually have, and then when it comes to disease biology, I think the only thing that makes difference here is in IgG and TP53, and the how sick is the patient when they come to you in the clinic. So because if somebody is really have got a bulky disease, then something that starts with venetoclax may not be a reasonable option because of the risk of tumor lysis. And then, patient's preference. So continuous versus fixed duration, oral versus non-oral, obinutuzumab containing versus non-obinutuzumab containing based on their infection risk. So is chemoimmunotherapy an option in 2025? I would like you to look at the history of FCR. So yes, we agree that FCR can actually lead to sustained remission. This is the data from the FCR 300 study. In that study, people who are enrolled at MD Anderson, they continue to entertain a very nice and durable remission, mainly for those who've got an IgG mutated. So the median PFS is about 14.6 years. In the unmutated, their PFS is very poor. So you're looking at 4 years, and in those with TP53, their outcome is even more dismal. So this is a long study. Median follow-up is 19 years, and so you will be maintaining an 18% of those people to be disease free at the median follow-up of 19 years. So we always agree that in the young patients, IgHV mutated, non-TP53, FCR is an okay option, but at what expense? At the expense that 6.3% of those people, they will unfortunately require, get a secondary malignancy, mostly a therapy-related myeloid neoplasm. And once somebody is diagnosed with therapy-related myeloid neoplasm, the chance of them dying from this very shortly is 84%. So I think the risk is actually quite decent that 6 to 7% of those people will develop a secondary malignancy. Now, are we getting an advantage when it comes to overall survival? I think the answer is no. There is no difference in survival. So the FCR data is very long, and we've got 24 years of follow-up from the FCR 300. But I can show you that early data from the E19, from the ECOG 1912, have actually shown you that ibrutinib rituximab at 8 to 10 years still carries exactly the same overall survival. So it's a safer option, does not carry a secondary malignancy risk, and the early data is comparable when it comes to survival. Same thing can be said about the CLL13. So venetoclax obinutuzumab is not inferior, at least in the initial 6 or 7 years of follow-up. So the ECOG 1912, in my mind, is actually an excellent example of an Eastern Cooperative Oncology Group driven study. So this is not a pharma-sponsored study. And in that study, they randomized people to FCR versus ibrutinib rituximab. And we know that addition of rituximab to ibrutinib does not add too much. And we'll talk about this from the Alliance. But FCR versus ibrutinib, the PFS is remarkably much better in all patients when it comes to ibrutinib compared to FCR in younger than 65 who are not TP53 mutated. In the IgHV unmutated patients, the difference is still maintained. In the mutated group, the difference is actually still there. So the PFS is much better with ibrutinib versus FCR. So now, the group that we always wanted to treat with FCR is the IgG mutated non-TP53 patients. But again, we are not doing any better compared to just an oral medication that the patients will take. And I'm sure you've seen that the overall survival after a very long follow-up of 7 years favors ibrutinib rituximab compared to chemoimmunotherapy. So that's why I think if you've got a therapy that is showing an overall survival advantage, I think it makes the other therapy less favorable to patients. Now, we can actually continue to argue that FCR is limited duration, ibrutinib is continuous therapy. I think that's totally fine and acceptable. But the cost of FCR in my mind, is about 6% to 7% secondary malignancy, which is quite serious. So the Alliance was one of the initial studies that brought ibrutinib to the market. It's an old study, published so many times, but the last publication was in 2021. And in that study, the enrolled people who are actually above the age of, they're actually mostly seniors, so the median age is 71, but the age is between 65 and 89. A small number of those people are high risk, so 10% TP53, but 60% are IGHV unmutated. And we've learned that the PFS of chemoimmunotherapy, bendamustine rituximab, is very poor compared to any ibrutinib-containing therapy. So ibrutinib, in my mind, have done better compared to FCR, have done better compared to bendamustine rituximab in above the age of 65. We've also learned from the Alliance that rituximab does not add anything to those patients, so the PFS curves are actually exactly similar. So when it comes to overall survival, the curves might actually look quite similar, but certainly there is the follow-up here is about 5 years, so it's a short follow-up for a CLL study, but certainly the statistically significant overall survival advantage have been shown with the use of ibrutinib-containing regimen compared to bendamustine rituximab. So there is 5 to 15% improvement in overall survival, depends on the length of follow-up, between the bendamustine rituximab arm and ibrutinib in favor of ibrutinib-containing arm. So if we actually look at all subgroups, you can certainly see that the benefit is in high risk and also in the non-high risk patients. So PTKI-based therapy is better than chemoimmunotherapy, and it also offers an overall survival advantage. So now, what's the price that we're paying for targeted therapy? With ibrutinib in particular, there's some cardiovascular risk, and that risk varies from hypertension to atrial fibrillation to, in rare occasions, ventricular fibrillation. But that's something highly associated with ibrutinib and less associated with the second-generation PTKIs. But hematological toxicity can be seen with chemotherapy. We understand that. And it's much less with the targeted therapy. AFib and hypertension are way higher with ibrutinib compared to chemoimmunotherapy, and that's quite understandable. If you actually look at the AFib all grades, it's about 20%, and hypertension is about 25 to 30%. The incidence of AFib, as well as with hypertension, the median time to this side effect is about 18 months. So it's actually a cumulative incidence, and as long as people are taking their therapy, the risk continues to go high. And I think if you actually counter the effect of age on those patients, you're always looking at about 2% of the population above the age of 65 who will get AFib without therapy. So the baseline is about 2%, but with ibrutinib, the number goes really high to close to 15 to 20% over the 2 years follow-up of the study. So it's a serious side effect that is specific to ibrutinib. Hypertension is exactly the same. So the baseline is about 20%, and this goes as high as 50, 60% by the end of the study. So this is on the left side. We've talked about the ECOG 1912. So the British study, the NCRI, FLAIR study, have shown a similar data. The caveat here is the length of follow-up is actually much shorter. So most of the endpoints have not been met, but the PFS with targeted therapy is much better compared to FCR. The overall survival was not mature for this study. And this is the comparison between both studies. And again, the all comers in the NCRI and all comers in the E1912, you can see the overall survival is actually much better with the ibrutinib population compared to the chemoimmunotherapy. And the usually differences comes with time. But I mean, this is a short follow-up study. We have not seen the separation quite yet. So what are the approved therapy in the front line? We have so many options, but when it comes to BTKIs, We've got the covalent binders, so ibrutinib, acalabrutinib, and zanubrutinib. They've got, certain kinase domain selectivity, and, based on the off-target effect, you get side effects. So in the ibrutinib, there's quite a significant tyrosine kinase effect, which is something we all like, but at the same time, there's a non-tyrosine kinase off-target effect, which leads to significant cardiovascular toxicity, and in some patients, also some dermatological, side effects. And the effect on eGFR is actually much higher in the ibrutinib than with the other BTKIs. So acalabrutinib is more selective, and zanubrutinib is more selective. And there's also other BTKIs that are not commercially available, but they've got even way more selectivity toward the tyrosine kinase. So looking at the second agent, which is a part of a second generation BTKI, the acalabrutinib. So acalabrutinib has been looked at in 2 studies, the ELEVATE-TN and ELEVATE-RR. So the ELEVATE-TN, they use the backbone of obinutuzumab with chlorambucil, and they actually randomized patients to receive either acalabrutinib with venetoclax, so with the obinutuzumab, sorry. So acalabrutinib with obinutuzumab as a continuous therapy for the acalabrutinib, and the obinutuzumab is only 6 cycles, versus acalabrutinib alone, or acalabrutinib plus obinutuzumab versus acalabrutinib alone. So we can see that the PFS certainly favors the acalabrutinib obinutuzumab arm compared, and it's actually not too bad for the patients who are receiving just acalabrutinib monotherapy. But people on obinutuzumab with chlorambucil, they actually don't do very well, and I think you can see this is for an obvious reasons. When it comes to effect of bad genetics, so 17p and TP53, both groups who are receiving acalabrutinib, they've done actually quite well compared to chemoimmunotherapy, and I think that's something we can understand. So the median PFS at the end of the study, which is 5 years, 70% are alive and disease-free. This is if they have a TP53. If not, then the acalabrutinib obinutuzumab, almost 90%, they're actually alive and free and disease-free at a median follow-up of 58.2 months. Did we see a side effect profile similar to ibrutinib? I think the answer is no. Acalabrutinib is certainly much safer to ibrutinib when it comes to cardiovascular side effects. So AFib, we've talked about 25% in the ibrutinib. It's about 7% all grades, and the same number is in whether you use obinutuzumab or not. The hypertension, same thing. You're looking at 8% versus 9%, and then infections are quite often, and the infections are actually much worse if obinutuzumab is the backbone therapy. Secondary malignancy, I think the numbers are about 15% in the acalabrutinib versus less than that in the chlorambucil obinutuzumab, and I think it's a function of those people are continuing to be on therapy, and they actually live longer to get a secondary malignancy compared to the chlorambucil obinutuzumab arm. So the Sequoia have got multiple arms. The Sequoia is a study that randomized zanubrutinib to bendamustine. So the initial cohort is all comers, but they've actually managed to exclude people who have got high risk genetics, and they exclude people who are actually suitable for FCR. So all of those people are actually higher age patients, so above the age of 65, or if they have comorbidities. But you can see from the zanubrutinib monotherapy, the PFS at about 3.5 years is actually similar to the ELEVATE-TN. So 82% alive and disease-free at the end of follow-up. And if you actually take cohort 2, the number is actually quite similar, so 80%. So cohort 2 is the people with deletion 17p. So they still do actually quite okay, and these results are not too different from the acalabrutinib. So the cohort C is particularly for people with TP53 mutation, and the numbers are published as of last ASH, and the data is exactly similar to what you see in cohort 2. Any differences when it comes to side effects? I can tell you from using zanubrutinib that the hypertension numbers are not too different when it comes to zanubrutinib and ibrutinib. So the numbers in this study, the reported all grades is about 6%, but on continuous therapy, the Alpine have shown something close to 15 to 20%. And the safety profile is not too different when in the cohort 1 versus cohort 2. The cardiac side effects is actually much lower to ibrutinib, but again, this is a cross-study comparison, and we're always discouraged from doing this, although we keep doing this. So does 17p deletion affects the BTKI outcomes? I think the short answer is no. The study from the National Heart and Lung Blood Institute have shown that people who continue to be on ibrutinib or zanubrutinib or acalabrutinib, but in this particular study it was ibrutinib, the overall survival is quite excellent and similar to overall survival of those people without TB53 or 17p. If you give them a continuous BTKI, their PFS is also not bad at 4 years. And also at 6 years, you're looking at 6 out of 10, they're alive and disease-free. I think these data can be replicated with the second generation BTKIs. So now, in the Elevate TN, the high-risk patients, as I showed you, they actually did they did quite okay compared to the chemoimmunotherapy arm. So the patient with T53 will probably benefit from BTKI's continuous therapy rather than any other form of therapy. So the Sequoia cohort 2, and this is something we've discussed, the outcome is actually quite great at end of the study, but keep in mind the median follow-up is only 48 months. So what are the side effects? I'm sure you've used BTKIs. I'm sure you've seen all these side effects. Bleeding, we worry about the mild platelet aggregation inhibition. So the preoperative management is quite important for those people who are coming for surgeries. But at the same time, mild bruises and mild ecchymosis can be seen. Infections, it's something we've seen quite often, but we don't actually do anything beyond just vaccinations. So we don't actually give them prophylactic antibiotics or prophylactic antivirals in practice. But more importantly, I think you have to see those people quite often. So, initially in the first year or so, I see those patients every 1 to 2 months in the clinic just to make sure that we get their blood pressure readings, and if they have palpitation, or sometimes we get the usual the odd patients, we ask for an ECG. But we always worry about AFib and flutter, especially with ibrutinib and hypertension with also zanubrutinib. So this is something we see in the clinic. It does not mean we stop therapy. We try to manage those people medically as we can, so we can sometimes give them anticoagulation. We send them to our cardio-oncologist for evaluation, and most of the time they'll just add on a beta blocker if they have AFib that is managed and controlled. So have we compared acalabrutinib and zanubrutinib to ibrutinib? Yes, we've done, but mostly in the relapse setting. But if you actually look at Elevate RR, which is a study that compared acalabrutinib versus ibrutinib as a phase 3 in people who are previously treated. So the outcome, again, this is a non-inferiority design, but the hazard ratio when it comes to PFS is 1. So there's no difference when it comes to progression-free survival between acalabrutinib and ibrutinib, but the study was actually designed to look at safety more importantly. And you can see that by using acalabrutinib, you're doing a 48% risk reduction of AFib and A-flutter compared to using ibrutinib. So it's quite important to keep this in mind. And same thing can be said about hypertension. 70% risk reduction of hypertension if you use acalabrutinib versus ibrutinib. And these are the data we've got from the Elevate RR. So the Alpine is the same thing. So it's a phase 3 that are used in the relapse refractory setting. So Zana versus ibrutinib, and the outcome here is different than the Elevate. So the outcome here is the overall response rate. But keep in mind that the PFS is super excellent with zanubrutinib, a tiny bit less with ibrutinib. And, this is for so many reasons. Probably some of them is the safety discontinuation rate and so many other things. but the PFS is better with acalabrutinib, with zanubrutinib compared to ibrutinib. We've concluded, also that AFib is most certainly lower with zanubrutinib compared to ibrutinib, but this is exactly what I told you about, that hypertension. You've got two signals, in the alpine, hypertension is similar to ibrutinib, but if you actually look at other studies, zanubrutinib, for example, in the Sequoia, the percentage was actually much lower compared to alpine. So I don't know if this is an anomaly or not, but I think in my practice, if somebody is on ibrutinib and develop hypertension, I rarely, switch them to Zano. I would prefer to switch them to acalabrutinib because I think it carries a lower hypertension percentage. So venetoclax combination. So in the front line, people have used venetoclax in the CLL14. So the VO is a regimen that has been looked at by Uthman al-Sawaf and his team. It's actually a very nice regimen. The good thing about this is, the patients, they actually remain BTKI naive. They've got a great second option or a second line option. So we agree on all of that, but it's not actually the most efficacious, regimen when it comes to PFS and overall survival. So you see the PFS curve, drops, quite quickly compared to BTKI's, curves that we've seen in the past. But the median PFS at this study in the VO arm is about 76 months, and the 6 years PFS is about 53. So it's a tiny bit lower than PTKI. But again, this is across trials comparison. Overall survival after a median observation of about 75 months, the overall survival favors venetoclax obinutuzumab compared to a very poor backbone, which is chlorambucil obinutuzumab. So it's better than chlorambucil for sure, but in my mind, it might not be the most efficacious, for the newly diagnosed patients, unless they're frail and they actually they want to avoid the complications of BTKIs, mainly the cardiovascular complications. It actually works quite okay. The good thing about VO is it's a fixed duration therapy, but the worst thing about this is people who are actually 17p deleted, they actually don't do very well if you stop therapy. So if you see that the TP53 population, so the study therapy will stop here, and the survival curve actually, or the PFS curve goes very bad. Same thing can be said with the IGHV mutation. So the people who are actually IGHV mutated, they still do okay, but the unmutated arm, they actually go as if they're receiving chlorambucil obinutuzumab with an IGHV mutation. So it's a good combination. Again, VO is nice, but if people are not IGHV mutated, if they are not TP53 mutated, and they are IGHV mutated, so you have to select, your patients, quite carefully for this regimen. The MRD numbers, we can talk about this all day long, but it's not something we actually employ in our practice. So I think we'll skip this for the sake of time, but we know that MRD depth of response, correlates to cumulative survival. So those who achieve a deeper response, they do much better compared to less of a response. What are the side effects? I'm sure you've used venetoclax in your AML patients, nothing that you've never seen before. So severe cytopenias can be expected, but more importantly, the combination of obinutuzumab leads to some sort of infections, but this is also in the comparator and control arm. So the last kit in the block is the Amplify. So the Amplify is a very interesting design. So this is a study that are designed to compare acalabrutinib with venetoclax versus acalabrutinib with venetoclax with obinutuzumab. So you actually throw the kitchen sink on those patients versus FCR if they're younger than, if they're FCR candidate, or bendamustine rituximab if they're bendamustine rituximab candidate, so above the age of 65. And the main outcome is PFS, and the secondary outcome is everything you would imagine. So this study is designed to give therapy for a certain duration of time, and then the treatment will stop, and the patients will be followed. So now the study medication will stop here, and then the patient's follow-up will continue. But you can see that the progression-free survival favors the triplets, so AVO compared to AV, compared to chemotherapy. And we can actually see that their PFS is super excellent with AVO, so 83% at 36 months. So it's a short follow-up study. The median PFS, is not reached in the ACALA containing arm, and it's 47 months in the chemotherapy or chemoimmunotherapy arm. The hazard ratio for death, again, certainly favors the combination of AVO compared to chemotherapy. But the bad thing, for the company is this study was actually done during COVID. So the PFS, certainly favors AVO compared to AV, compared to chemotherapy. But looking at the overall survival, this signal was not translated to overall survival. When it comes to PFS by IGHV mutation, you can see that honestly, when you use the combination AVO, it doesn't matter whether somebody is mutated or not mutated. The curves are exactly the same. If you're using AV alone, then the mutated group, they do a tiny bit better. But again, the outcome of the unmutated is still reasonable. Those who receive chemotherapy, they actually don't do very well if they're unmutated, and they do reasonably okay if they are mutated. But again, the TP53 alteration is not allowed in this study. So MRD assessment, we don't actually have to look at the table to understand that if you give triplets, the MRD depth of response is higher, and this is something you can see more in the AVO compared to AV compared to chemotherapy. And chemotherapy, as we know, does not give you an unreasonable depth of response. So undetectable MRD by end of study. So AV combination versus AVO versus chemotherapy. So the triplets have got 80% chance of undetectable MRD by next generation sequencing compared to the initial one, which was by flow cytometry. So now overall survival, and this is actually a striking point here. So the overall survival of patients with AV is actually super excellent. So by the end of the study, almost everybody is alive. Unfortunately, the AVO combination, the survival have dropped a tiny bit throughout the study and became similar to FCR and benoacid rituximab. And my interpretation of this is because of obinutuzumab have contributed to quite a bit of COVID deaths. So if you actually do a subgroup analysis and eliminate any cause of death from COVID, the AVO group will do quite okay. So this is overall survival with COVID death censored. You can see that the AVO group have done quite excellent and similar to the AV population compared to chemotherapy, but without censoring COVID. The addition of obinutuzumab was not a great thing to do for those patients at the time of COVID. So again, this is something I want you to look at. So total deaths in the AV arm, you get 18 deaths. In the AVO, it's 37 deaths, and in the chemotherapy, it's 42. So the 37 has became similar to 42 because of COVID. So obinutuzumab has led to a lot of immunoparesis, and those people did not do very well when they had COVID infections. What are the side effects? I think you can tell that if you give them the triplets, that the amount of cytopenia is actually significant, but it's not too different than the AV, and certainly neutropenia is also seen with the chemotherapy. But the febrile neutropenia rate is higher with chemotherapy, and I think because of the depth of cytopenia they see after chemo. So 10% they've got febrile neutropenia compared to 1 to 2% in the AVO or AVR. So that's pretty much the most striking adverse event. The cardiac events, nothing that you have not seen before. So again, 10% they'll get some sort of AFib. Very rarely, out of 200 patients, 2 have developed ventricular arrhythmias, and the same number can be said about AVO. So the infections, I think the addition of obinutuzumab, will double the risk of infection. So it goes from 30% to about 50%. Any grade infections. So this is something we always keep in mind. Last thing we'll talk about is how do you manage or how do you navigate venetoclax-associated toxicity. So definitely tumor lysis is something we worry about. So we try to stratify those people. Sometimes we start obinutuzumab early and then we add on venetoclax. Sometimes we add on the acalabrutinib first for a couple of 3 months, and then we add on the venetoclax. So we try to debulk those people early on before we introduce venetoclax. So we do, some sort of a risk assessment. And then, the debulking strategy could involve either giving chemotherapy or obinutuzumab or starting with a BTKI. Obviously, I don't have to mention that, the allopurinol and hydration is very important. So the Gaia is the backbone where the CLL14 have taken over. So the CLL13 or Gaia study it had exactly the same question of the VO versus venetoclax rituximab versus chemotherapy versus the IVO. And then the CLL14 have actually followed this when it comes to design to answer the question of VO versus chlorambucil. So it's a good combination, but ibrutinib based against VO, against venetoclax rituximab, against chemotherapy, and these are actually fixed duration finite therapy therapies. So when it comes to undetectable MRD rate, you can see that the IVO have the highest undetectable MRD rate compared to VO, compared to VR, and chemoimmunotherapy. And this tells you that venetoclax monotherapy is not very helpful, and the VR numbers are not too different than the Murano clinical study outcomes. When it comes to the median PFS, the IVO group have done much better compared to VO group, who are actually not too bad. And then the worst groups are the chemotherapy or the Murano, the venetoclax rituximab arm. Median PFS at 3 years is 90% versus 87% versus 80. So now the conclusion of the obinutuzumab and rituximab debate is, we have certainly noticed an improvement of PFS and overall survival in the use of obinutuzumab compared to rituximab. I do not think rituximab adds anything to CLL patients in contrast to obinutuzumab. VO beats aggressive chemoimmunotherapy in patients with undetectable MRD, but the use of venetoclax and rituximab does not. So VO is much potent than venetoclax rituximab. This is from the CLL13. Now, keep in mind that obinutuzumab is IV, it's infusion, it causes infusion reactions, it requires pre-medications, it has a lot of side effects like infections. So it's a discussion that we always, have with our patients. What's the optimal frontline? I think, the treatment is changing. There is no best single answer. So the E1912 have shown 78% overall survival, PFS at 5 years. The Elevate-TN have shown similar number. The Elevate-TN combination, acala, obinutuzumab, 84%. The Sequoia monotherapy, 80%. So great, PFS for all these combinations. One size does not fit all. So the selection is very important, and keep something for salvage. And we have not talked about, CAR T and bispecifics as an option for those who relapse, after venetoclax, BTKIs, and also non-covalent binding BTKI. So we've covered this. I think we'll leave room for questions. And in summary, the field is changing. No therapy fits all patients. So the chemoimmunotherapy is certainly out, but combinations are coming for patients, and continuous therapy is still reasonable. That's pretty much it. Thank you very much for being so patient with me.
Wow, thank you very much for that. I've already got a few questions that have come up on my side, and I must say, as the questions came up, you answered them as we were going. So I think it was a really, really good talk in terms of just trying to understand what the landscape is looking like. Really, really appreciate it. I think we're going to open out to the floor and just check if anybody has any questions. Just looking into the chat box. Please raise your hands if. Okay, so I'm going to start off with a question so long. So I loved your final slide where basically you said that, the first line in CLL really actually difficult to just say that this particular regimen or this particular approach is the way to go for therapy. There's so many factors that influence things. And I just wondered in your real world kind of experience, how much adherence and quality of life impact treatment choice. Especially as we notice that there are limited fixed duration options for older patients. Yeah, I'd just love to hear what your experience has been there, what your thoughts are on that.
Yeah, I mean that's actually very important. CL. So I don't know about the landscape of CLL in South Africa, but I can tell you in Saudi, it's actually a rare disease. So it's not a common disease compared to the West. The number of patients, in the majority, we're diagnosing people at their end of 60s and early 70s. It's not uncommon to see somebody in their 40s and 50s, but it's not the majority of the patients. So if somebody is in the end of 60s and early 70s, and they actually are not harboring high risk genetics, I think it's very reasonable to give them a fixed duration therapy that it does not impair their quality of life. I think VO is quite reasonable, and then you stop at 2 years. They will probably enjoy another 4 years of therapy, and then they will come back, and you can probably give them a continuous, BTKIs. So, but by that time, they've reached the median age or the median, survival for their age in the country. I've got patients who will say, honestly, you've got, people who say, listen, no admissions, no troubles. I need something that is, very manageable, and I would like to go on with my life. And we, without hesitation, we give them a second duration BTKIs and say, you know, be my guest. I'll see you back every 2 months just for a quick check and make sure your blood pressure and your heart rate, remains okay. So a good number of patients, who are in their 70s, we'll just give them a continuous PDKIs, mostly, acalabrutinib and zanubrutinib, honestly. In the younger population, less than 65, I think we have to invest on trying to give them the most efficacious therapy. And this is when we talk about a combination, acalabrutinib, obinutuzumab, either continuous therapy or we can stop. A venetoclax-based combination is something we definitely utilize for those younger patients. In combination with BTKIs. We don't like to give VO for young people, honestly. I mean, we keep saying this, but VO for young people is not a great option. It'll come back in 4 years with a more aggressive disease and more likely a TP53 mutation.
Mm. Well, thanks for that. And actually, just leading on to now, you mentioned about obviously not VO for young patients. My next question was going to sort of look into how do you sequence therapy. I have to just say a big disclaimer, though, in terms of the backdrop of the South African context, and that is outside of a clinical trial or high-tier medical aids. Most people are not going to access a non-chemo therapy option. So for the vast majority of patients, the first line often is chlorambucil, especially for older, more frail patients. And for younger patients, it will often be FCR, even in funded patients,
Right.
unfortunately. But there is sort of expanding access with some of the centers having access to clinical trials, and of course, the funders coming on board in terms of being able to access the non-chemo options. And so with that in mind, it becomes quite important to sort of think very carefully if you're going to be able to access a non-chemo therapy for a non-chemo treatment for a patient, how to sequence it in terms of cost, duration, and efficacy.
Right.
So
Yeah,
when
that's
you,
so now I think we have to go back to the relapse refractory clinical trials. In those people, most of those people have received chemotherapy, and the majority of the world, I would say, quite confidently that they still get chemotherapy as backbone in CLL. We keep bringing this literature, but I think I agree that in Saudi we don't actually use chemotherapy as an option, but in the neighboring country, anytime I give a talk, you go to Egypt, you go to Kuwait, you go to most of the Gulf countries, they actually use chemotherapy. So when those people relapse, I think there will be so many factors that, are important. their genetics is very important. So definitely, if they harbor a TB53, I think just continuous PTKI is a way to go. And if not, then the outcome from the Murano data, so venetoclax rituximab, is actually quite excellent in post-chemotherapy relapse. And then if they relapse, then they've got the option of PTKI, and if they relapse, they've got the option of non-covalent PTKIs. So you've got four things in line. Now, if you say, well, you've got every options now. So now they relapse post FCR. 10 years later, they've got CLL again, and we've got everything and on the table. I would say if they're fit and young, I think the combination of AV is a great option. Again, FNI therapy, acalabrutinib of venetoclax, and then you can stop at 14 months and then watch those people. If they relapse, you can actually even go back on the same therapy, or you can actually switch again to another target like BCL2 plus CD20. So that's in a nutshell, but I think there's so many caveats here.
No, definitely. It's actually nice.
And allogenic transplant, and we rarely talk about an allo transplant, but this is not myeloma. In CLL, there's quite a decent graft versus lymphoma effect in the young people who are, especially after the initial. In my mind, I think I'm not a transplanter, but I refer every patient's post PTKI and BCL2 relapses. They have to get a transplant consult because it's still carries a good cure chance.
I think transplant is certainly still an option in our setting for very young patients.
Yes.
I personally haven't been involved in a transplant for a patient with CLL as yet, just one with Richter's, and she actually did fairly well. She had a haplo stem cell transplant and actually, has had a good outcome.
Yes.
So definitely, and it's quite good to hear you talk about allogeneic transplant because obviously that's fallen away from a lot of the discussion.
Absolutely. I still get a guy from, he was transplanted by a very senior hematologist who retired like 15 years ago. He still comes to the clinic now like once a year. This guy reminds me every time that, transplant does actually work. This guy, he received FCR, I think, or bendamustine rituximab in 2010. And then
Wow.
relapsed
That's
like 2 years later and got a transplant. He's now 15 years disease-free, and sees me in the clinic. So I can tell you, I don't do anything. I just say hi to him and check his immunoglobulins.
telling me still fine.
Exactly. Yeah.
Here's one thing that I also wanted to find out about is you highlighted the infusion reactions with obinutuzumab being quite severe, actually. And I'm curious, is there ever a role to switch from obinutuzumab to rituximab or the other way if there has been a reaction?
I think rituximab doesn't do anything to CLL. So if somebody's developed a bad reaction to obinutuzumab, then just omit obinutuzumab. And there's an art to using obinutuzumab, honestly. Yes, the label says you start with 100 and then you go to 900 and then you go full dose in 2 weeks. But the pre-medications are very important. People shy away from using steroids. We actually hammer them with so much steroid so much hydrocort on the initial day, on the second day, and they actually tolerate this quite okay. So I think most of the reactions are manageable if you're pre-medicating very well. And that pre-medication will include, diphenhydramine, hydrocortisone, Singulair. So we use a lot of Singulair as well as a pre-medication. And then, if really they cannot tolerate this, then I think omitting this is reasonable. I would not switch to rituximab. I do not think rituximab adds anything to any CLL cell. So now if you say, well, what about rituximab with venetoclax? I would say,
That was going to be my next.
we do not have any data that looks at this in the front line. The data we've got from the second line is reasonable, and the venetoclax, obinutuzumab have not been looked at in the relapse setting. So rituximab is helpful in the relapse setting, but in the first line, don't bother.
Not much of a role there. Yeah. I think this has definitely been an interesting discussion. I want to go back to the chat box and see if anyone has left any comments, or if they're stunned into into silence. Okay, no, I'm not seeing anything there. I have more questions. They will keep coming.
Yes, please go on,
Yes.
Gogo, because you ask excellent questions. So you speak for us all. And no, brilliant talk. Thank you, Dr. Alutaibi.
It's always it's always a great pleasure to see you guys, and I've heard so much about Dr. Fairpro from previous groups, so it's nice to see you, Estelle.
That's great to have you with us. Please, Gamu, ask your ace questions. They're great.
Okay. I am going to ask one more sort of question. I think this one you already kind of answered, but I do want to know if there is any emerging data for any other options for older patients with fixation therapy, or are we, if you've got TP53 mutated disease and you're older, then it's continuous therapy and that's it, or is there emerging data in that area?
So in the elderly patients who are TP53 in the relapse setting, so
Yeah.
so I mean the most of the guideline will still actually give venetoclax or obinutuzumab as an option, and even in the elderly patients who are at high risk. So VO remains an option. In beyond these relapses, or I mean beyond chemoimmunotherapy, and if they are BCL2 refractory, I think going back to BTKI as a monotherapy is reasonable. And I don't think there is an elderly patient who cannot tolerate BTKI, so you don't really have to go full dose. Most of the time in the era of ibrutinib, and ibrutinib now is being generic. So, we actually used to give them three capsules, and if they cannot tolerate this, we give them 2 capsules, and if they cannot tolerate this, then we give them 1 capsule. So there's quite often patients will end up on 140 milligram of ibrutinib, and they actually do quite okay. The numbers remain okay. Definitely lymphocytosis as a side effect is something we see with BTKIs, but their cytopenias improve, their B symptoms improve. So now, what if they actually are beyond that? I think pirtobrutinib is a next line of therapy, and that's quite effective as a bridging therapy. It doesn't actually work quite well in those who are venetoclax exposed in the past. But it brings people to about 18 months of PFS. So I consider this as a bridging therapy. And unfortunately, there's nothing much you can do for an elderly patient if they cannot tolerate this therapy. I think you're looking at CAR-T, or you're looking at good data about ibrutinib use in beyond the 3rd relapse.
Okay. Right. Well, thank you very much. I just want to check in with Nicola that I have not missed anything in the boxes.
No, that's
Nope,
everything. Thanks, Gamu.
that's everything. Okay, no problem.
It was so great to have you with us this afternoon. So,
Thank you very much.
yes, have a lovely afternoon.
You as well. Thank you very much, guys.
Thank you
And
very much.
everybody.
Mm.
Bye.
Bye.